I am really delighted to be able to introduce our first speaker, Elizabeth Brunner. She is a registered nurse. Elizabeth is a master trainer for the board of the Fellow of Academy of Certified Directors of Nursing Administrators. She's also developed curriculum and authored books for the nursing home administration. Betty spent more than 50 years providing clinical care and services to seniors in nursing homes and assisted living facilities. She's been a nursing home administrator and director of nursing for several organizations in Wisconsin. Betty will discuss the challenges and guidelines to patient-centered care in a long or short-term facility. I give you Betty. She's Elizabeth, but
Thank you. Well, I am loving Michigan. It's so sunny and bright here today. In Wisconsin, we had quite the storm yesterday, so I got to the ferry at 4:30 in the morning, and there was no ferry to be had, so I got to see lots of Michigan as I drove over here then. So I'm going to talk to you about some of the challenges of Parkinson's in the skilled care setting. And the reason I talk about it is that besides being a director of nursing and an administrator, the last 4 years of my career, I was the vice president of operations for Alden in Chicago, and we serviced our patients in 38 facilities, and we serviced about 5,000 patients in the northern suburbs. And my role and responsibility was to really look at the type of residents we were serving in the nursing home area and how many days people would be staying and how we transition patients to their next step of life. And there's, let me see, are we advancing here? All right, am I supposed to be pointing this? We were advancing before. So why, okay. Okay, are we ready to roll? All right, we'll be flexible right there. All right, the magic arrows, okay. So what I've been told with the audience, that we have personal caregivers, spouses, partners, family members, support people, physicians, nurses, professional resource providers, and advocates of care. But why me? Well, first of all, being a registered nurse, I know hard to believe, but like I'm one of those really old nurses. I've been around since the 60s, and I've always worked. I was a licensed practical nurse, then an RN, and went on with my professional life. I was a skilled care expert and still go and train for the National Directors Group. I'm also traveling around the country right now and helping identify people with changes of condition and to avoid readmissions to the hospital and really help facilities understand how to deliver care and service right in their facility. But most importantly, I'm going to kind of do it in a 360 manner. Because you see, 5 years ago, I was one of those caregivers. Not necessarily Parkinson's, but my husband had a stage 4 glioblastoma multiforme. Never been sick a day in his life. Had a little tremor, went to the doctor, and he was taken into surgery immediately where they found a brain tumor. And like some of you in this room, some of you have to be the deliverer of what the next step is in a person's life. And for me, my medical brain was looking and hearing things, but as a wife, an advocate for my husband, it was devastating. The doctor walked into the room. We were told that my husband had an encapsulated brain tumor. They were looking at Parkinson's disease, and that we would have a plan. And instead, the doctor walked in the room very quickly and said, "I'm very sorry to inform you, but this is a stage 4 glioblastoma multiforme, and the normal lifespan is 3 months to 22 months. And our life had changed immediately, just like people who are diagnosed with Parkinson's disease, just like the spouses and family members, because what we had was over with and how we were going to move forward. I just brought a cute guy on stage. It's morning. Okay, relax. Okay, now let's see what's going to happen. Cool. And so it was extremely important for me, with my husband's disease, to clearly understand how I would care for him. But I also have a leadership role. And in my leadership role in a healthcare setting, I look to train people on what I want you to look at when we admit patients to a nursing home. Now understand, nursing homes of today have changed enormously. When people hear you're going to go to a nursing home, people think of it as a life sentence, when reality is you're going to be at a nursing home for X amount of days, and from there we're going to transition you either to home, or maybe to an assisted living, or maybe you're going to partner with a home health agency. But my role and responsibility as a clinical leader was to teach my staff in all of our nursing homes, and we did have 5,000 employees, that when we're going to admit someone with Parkinson's disease, when you come to our facilities, it's going to be a center of excellence. And that meant staff need to be trained. So, what do you need to know? Well, if I'm going to admit someone with Parkinson's disease, I want you to be aware that that patient is going to be slower in their movements. They're not going to be in and out. Just like my husband, whose brain was sending the messages a little bit slower, and 2 different times during his diagnosis, he stayed in a nursing home. So when it said, Dale, you said you wanted to get up for breakfast at 6:30, that didn't mean Dale's old brain would have been up and out of bed and dressed. It meant we needed to plan out. It was going to be a little bit slower. He had decreased facial expression. Now let me tell you, as a wife, there were things that I lost right away, because as his disease progressed, I missed that grin. And as a matter of fact, there were times that I had to remind myself that because of his neurologically, the messages weren't coming through, I wasn't getting the reaction that I normally did. Those emotions as a couple. We were married for 44 years at that time. We knew each other's language, we knew each other's emotions, and all of a sudden as a spouse, I thought he was either upset with me when we'd go for a doctor visit because I couldn't read his facial emotions anymore. I would laugh at things and he wasn't laughing, and it's like, what, you didn't get my joke? What's going on here? And so I had to learn how to be a different wife. And here was the other thing. My husband's role, when his brain wasn't working as well, he went from being a police officer, you know? And as a police officer, he was the protector of our family. And because of his diagnosis, that protective role he had to give up. And I had to take on. I was used to leaning on him. I was used to the smile. I was used to having his arm around me all the time. And that was done. And I had to tell the nursing staff, you know, if he's not smiling at you when he comes in, it doesn't mean he's being uncooperative. It doesn't mean he doesn't care, and it doesn't mean he's depressed. Please don't acknowledge and say, oh, he's depressed today. No, his facial emotions, I've got to be able to assess and reassess a patient better just to understand that. And so sometimes that clinical staff didn't recognize how he was feeling because he couldn't verbalize it. So I had to work with him on talking to the nursing staff. How are you feeling today? And then giving him the time to talk because he didn't have that anymore. His tremors, I had to teach my nursing staff at the nursing home how to take a look to assess why the tremors are occurring with all of our patients. Are tremors occurring because he has Parkinson's disease, or has the physician started a new medication, and is it a side effect of the medication? So it's very important for my nursing staff to talk to the spouse, to talk to family members, and to talk to the patient to find out, did they normally have these tremors, or did the tremors begin once the new meds started? And then talking and communicating with that physician to tell them, here's something new, how often it occurs, and at what time did that tremor occur? Was it after the meds? When we admit Parkinson's patients in our nursing facility, we automatically put them at a fall risk. The reason we do is because most of our patients that came in with Parkinson's disease had some unsteady balance. That was one of the reasons they came. And they could come to our therapy department. With our therapy department, one of the things we did was, instead of just saying our patients have a fall risk, what we did instead was we did a program in teaching our patients how to fall safely. Because a lot of times what happened in our nursing home with patients with Parkinson's is they minimize what is occurring. They might trip in their room. They might have a little slip. Or when they get up in the morning, they kind of will lean on some furniture or something just to get their balance. So what we did is we had a Here's How You Fall Safely program, because it was going to kind of be a fact of life in our facilities that this is an outcome that we could expect, and having that patient report to us when it's actually occurring. The one thing that happened, and I'll be honest, when I found out my husband had to go into a nursing home, now I'm the person, I've been the president of the Director of Nursing Council. I've worked in this industry for 50 years. I was afraid to tell the nursing home my husband's disabilities, because maybe they wouldn't accept him. Maybe they would put him on a unit that made him worse instead of better. Maybe they'd give up on him because they knew that he had an end-stage disease. So you minimize what you tell the nursing staff. And here I was, and I felt I was doing this balancing act between being the nurse and being the family member. And how do you make that work? How do you communicate? The other thing that my husband did, because his vocal cords and his voice, number one, he talked slower than he normally did, and it was very monotone with his illness. So a lot of times when nursing staff would walk into the room in the morning and saying, well, Dale, good morning, would you like coffee and want to go to breakfast? His voice is just starting to answer, and they didn't take the time to listen, and they moved on to the next patient and thought that he was ignoring, but he was just starting the voice. And he was minimizing his voice, and it was slower than it had been before. So he had an inability to keep up with conversations. And everyone was saying, okay, he needs more speech therapy. And I said, before we go to speech therapy, maybe he just needs more time. Maybe we have to slow down as caregivers and take a look at that individual person and look at their disease process and figure out what is it that they really need. And why does everyone have to be up at 7 o'clock in the morning? Is there a rule? Half the time, we have done things in healthcare, especially nursing homes, because we're so afraid of what the state government's going to do to us that, God forbid, not everyone's up and dressed by 10 o'clock, because where are they going? They're not going anywhere, you know? So it's kind of taking a look at, it's like learn to take the time. Learn to enjoy your patients. Learn to say, okay, on this group, we're going to do this. My husband, as his disease progressed, he became very rigid, and he couldn't bend over anymore. You know what was the worst thing for him with that? I'll show you. The worst thing for my husband that frustrated him more than anything else is he had his 4 grandkids that were always coming to visit. So we had to get everybody used to the fact that when you come and see Papa, he can't run and pick you up anymore. So we had to explain to the kids how to slow down, how to listen softly. And that's a challenge of this disease. That's the heartache of the disease. That's the loss. That's the loss. It's a different time. But these are little ones. And so it was learning that when Papa wanted to take a nap, guess what? Brock, you know what? Papa needs to take a nap. Could you take a nap with him? And he'd crawl up in bed with Papa at the nursing home and take a little snooze with him. But that was okay, because you know what my nursing staff figured out? That Papa loved to have his grandkids next to him, but he is running out of energy. And probably 5 years earlier at our nursing home, everyone told us we were going to be admitting bariatric patients. So what did this nursing home do? They bought 10 bariatric beds that were kept in central supply because the bariatric patients got better at home and not in the nursing home. But my staff figured it out, and they said, you know what Dale really likes? He loves, his happiness is when those grandkids crawl in bed with him and take naps. So they just took a bariatric bed out of central supply and put it in the room, and now he had a bigger bed for those kids to crawl in bed with them. That's quality of care. That's quality of life. That's compassion. That's what makes it happen. And let me tell you, at night when everybody left, even though I was the vice president of that company, I crawled in bed with my husband every night before I had to go home, because that's what we did every night. If you're in healthcare, usually by the time you get home, all you want to do is get a glass of wine, crawl in bed, and turn on TV if you don't have kids at home. And otherwise, it's make the quickest meal you can and still crawl in bed. So what I did is I got to crawl in bed with them, and it made all the difference in the world. So if you're in the situation where people are going to be short-term in your nursing home, ask them if they'd like to have a bigger bed, because believe me, the ones we're offering right now in the nursing home are just like a dorm mattress. And when you're used to sleeping in king-size beds, you don't see those little beds. It was kind of my husband's first words out of his mouth when we got to the nursing home. He goes, "So where are you sleeping?" And he goes, "You mean you're not staying over here?" I went, "No." And he goes, "Well, that sucks." He says, "I thought we were going to get better together." So, and then the other thing to take a look at, and we talked to our nursing staff about, is the shuffling walk, making walking extremely difficult and painful. So what we did on our restorative unit where our Parkinson's patients live, because they were there to get some therapy and then go home, is we made sure their rooms were closest to the dining room, because that way they didn't have to walk down that great big long hall again. So it was redesigning the home to make it. But what should be the non-negotiable expectations that you should expect out of a nursing home? Well, the first thing is to make sure there's a system in place to monitor care and service in the treatment of Parkinson's disease. So when people are looking for nursing homes and a tour is made, the family members and the residents should say, please tell me how you provide care and service to people with Parkinson's disease. Take a look at one of the non-negotiable things that can happen in a nursing home is the medication pass, because again, the state tells us that we're supposed to pass our medications at certain times, and we have a 2-hour gap in the windows of life to get meds out to everyone. Well, Parkinson's disease medications are different, and they have to be given at certain times. And my husband also had certain meds in his cancer journey that had to be given. And all of a sudden, he was in a panic the first day I came in, and he said his meds had to be spaced apart every 8 hours. And the nurses said, well, we only give them at 10, 2, and at 8 at night. And it's like, no, please help me to understand that you said you are a specialist in his disease, just like Parkinson's disease, and here's the non-negotiable times that his medications are to be given. And as an advocate for someone, or as you hear that in set-up times, and if you're a leader in healthcare, saying to your staff, no, medication administration is non-negotiable. These are the times these meds must be administered to address the needs of Parkinson's disease. There has to be a system designed to incorporate feedback from caregivers, from the residents themselves, families, and staff as appropriate if the resident has a change of condition. One of the big things that happens with anyone who comes to a nursing home, you have a general diagnosis, but the other piece of it is you have comorbidities. You may have congestive heart failure. You may have chronic obstructive pulmonary disease. And you have to take a look, be an expert on how congestive heart failure is affecting someone with Parkinson's disease and how you treat both to address any type of change of condition. For example, if for some reason a patient has congestive heart failure and they're at the facility, and all of a sudden when the caregiver goes to put shoes on in the morning, either the shoes shrunk 2 sizes or their ankles are puffy, that could be a sign and symptom of congestive heart failure. So if I'm a spouse and in the room and I notice that, what is the system to go and tell the nurse, I think that there's a weight gain because their ankles are puffy today? Or if all of a sudden they have a change in mood and behavior, how do we do that? How is he going to be treated, and what are the things that we can do? And sometimes just because they have Parkinson's disease, their joints and their muscles are crampy and achy, and what can I do for pain relief? What are the treatments, and what is put on the plan of care? So not just the day nurse knows what to do, the second shift nurse and the third shift nurse. So there's continuity of care on all 3 shifts. So the care processes and the outcomes of and monitoring using current clinical standards of practice, and I'll talk about that in a couple minutes. But taking a look at if there's any adverse events, how are they going to report that to the physician, to the family, to the patient? If you have an adverse event, how do you track it, monitor it, investigate how something happened? If all of a sudden the patient has a bruise of unknown origin, where did that bruise come from? As soon as you see a mark, do we immediately begin an investigation to find out where was that? And when you come into a nursing home, family members need to know, how is that reported? And then how is that information given to me? If there's a medication error, I can remember in some way back in the day as a director of nursing, if a nurse made a med error and you go to take a med, and you go to, well, I called the doctor and we're doing this. I says, have you notified the family? Do we have to notify the family? Yes. You must notify the family, and you need to notify the patient. There was a med error. We've notified the doctor. Here's our new intervention. And also, what are you doing to make sure those things never occur again? The other thing we have to monitor for is for infection, because there are infection control systems and processes in place. So how do we make sure if our resident does get an infection, what is the course of treatment? What is the outcome that we're expecting? And how do we keep that patient safe during it? These are the discussions the director of nursing should be having with family members when a person is admitted. And then, most importantly, a person-centered care plan interventions are updated, implemented, and communicated to the staff if you're changing something, the resident representative, and to the patient. And with the new regulations that are out right now, that resident representative and the patient should be receiving, once the first person-centered care plan has been developed, that they get a signed copy, and it's given to the patient and representative within 48 hours of admission. So on day one, when a patient comes to you, discharge plans begin the very first day. The reason you want to do that is because, as I told you before, most patients that come to the nursing home are only going to be there for, I would say, Parkinson's disease, anywhere from 12 to 17 days before that next transition happens, because that's kind of how healthcare is today, what we're seeing. So by day 17, you need to have what is the next phase for those patients. I can tell you the disasters that happened in my personal life. We got to the nursing home on day one. We gave the advance directives, and I'm sure they'll be talking about that in other sessions, but everyone knew what our plan was for my husband's advance directive, and being open and honest and discussing what you wanted, but the next step was going to be going home. So with the discharge process, one of the things they told me is, at that time, the reason he came to the nursing home the first time is that he was having difficulty standing. He had lost his strength in his quads. The message wasn't coming down from the brain anymore, so he was getting some therapy. So this was a nursing home where it wasn't one that a group that I was affiliated with. This was a nursing home near my home, a 5-star nursing home. They said to me, you know, you're probably going to have a sit-to-stand lift in your home when you get home. Okay, fine, order it. And you'll need home health. Great. What home health agencies do you recommend? Because if you wait till the day of discharge to get your home health agency, then you wait 3 days for them to come home, and then you're left by yourself for 3 days, which makes no sense. So the nursing home orders the sit-to-stand lift. Now, this nursing home had a interdisciplinary team that specialized in talking down to you. It was like, how do you feel about that? And I said, well, if I need to sit-to-stand lift, bring it on. I don't care. So we get my husband home, and what's the first thing that I go and say to them? So where's the sling? Oh, the nursing home didn't order the sling? Fortunately, I stole 2 gate belts out of there before I left that day. And I went, no, where is the sling? Oh, we didn't order it. That took 2 weeks. So, because the sit-to-stand lift sling was not ordered, for the next 2 weeks, I did all the lifting at home with the stolen gate belts. But the thing was, no one told me that. They also told me, at that time, he had a wheelchair that reclined, and we were able to get a bus to take us home, but they said, you need to be at the doctor's office for your next visit next week. No problem, I'm taking them. This is all about this wonderful question that no one ever talks about in any care plan. How much does it cost and what supplies do I really need? Where can I take my husband to the bathroom if we go out? Now, I will tell you, the best bathrooms God has put on this earth for handicapped people is Kohl's and Walmart. They are the only stores that have handrails on both sides. So wherever you're affected or need to grab, you got them on both sides. And they're close because when you walk into the handicapped bathrooms, it's the first thing you see. Everybody else, it's like 2,000 miles down the hall. And I've gone into a lot of men's restrooms. I didn't really care. I just would open the door. I said, nurse on board, taking somebody to the bathroom, go all and struggle and get all the way down there. Okay, fine. So I got the bathroom thing because nobody ever tells you that. Then they said, so now we don't have the slings. So now they tell me I have to get my husband to the doctor. They made the appointment for Monday. But how do I get him there? Because he has a reclining wheelchair. Well, you get to rent a wheelchair van. And some people are nodding. So the wheelchair van cost me, because I had to do a 4-day rental because his appointments were always on Monday. So that was the cost of $475 a week for the next 12 weeks. So it's wonderful in the discharge process that you sat down with me and told me all the things I needed to do, but you never told me how much it cost. So a lot of times, healthcare professionals, when we scratch our heads and go, well, gee, why didn't they follow through? They've had it. They don't have the money to do it. My husband was told one of the other things that before you leave the nursing home is communicate to the clinical team on day one, say, I would like to see my husband's diagnosis list. Now that might seem kind of crazy, but we've gone into the ICD-10 coding world right now that is going into effect. ICD-10 coding is totally different. It's a whole revolution in healthcare. So your husband or wife or your patient may have Parkinson's disease, but then everything else that's affected by the Parkinson's disease needs to be listed, and it needs to be in order. And then any active disease, like I said, if they have congestive heart failure, if they have diabetes, if they have any of it, all of that has to be listed as active diagnosis. This will affect how a person's prescriptions are paid for. This will affect how how many days of care you receive in a nursing home. This will affect outpatient services. So say to who's ever meeting with you on that first day, I need to see the diagnosis list and ask for a copy, because it'll go on your Medicare bill, it'll go on every type of billing with Medicare. It's always listed that way, and if there's something incorrect, it needs to be corrected. Now, why do I tell you that? When my husband was discharged from the hospital, I went back to work because, you know, we do have bills to pay, we have a house to pay for, and all of a sudden, they say to me, he calls me up at work, and he goes, oh, I picked up my meds, this chemo med. And I said, well, good. And he goes, and I put the copay on American Express. I figured you'd like the points, which usually puts a little acid in your gut when he said something like that. And I said, okay, since we have a $4 copay on all prescriptions, I'm imagining you needed a little bit more money. $2,878 a month for copay on one of his cancer drugs. And because I'm in the work that I do, I said, I did not react to my husband, because you're not going to react to your husband because this is going to keep him alive. But it was like, holy cow, $2,800 a month? What the heck's going on here? So I called the hospital back, and I asked to speak to the reimbursement specialist. And I said, could you please help me to understand how you coded my husband's diseases, because I have a hunch it was done incorrectly. She called me back and she said it was. So $2,878 went down to $70 a month. But who's going to know that? Who's going to know to go call a reimbursement specialist? It's only because I'm the Wicked Witch of the West and will look at everything and go, something tells me someone didn't do their job right. But think of all the people out there. We were in cancer clinics every week, and you'd sit down next to people, and family members and patients had made the decision already because they had a terminal illness. They weren't going to take those drugs anymore. They knew the end result, so why take the pills? Not for that kind of money. People make decisions that way. So please make sure that your ICD-10 coding is done correctly. And if you're a family member, a doctor, whatever, wherever it's being done, it has to be in order with primary diagnosis. When you go to a nursing home, you need to communicate to the clinical team what a day in the life is like in your home. So things can be adjusted to make things easier for that patient when they're at the nursing home. Taking a look at medication time and routines. And because you're going to be going home probably within 15 to 17 days, right away say, I want to be able to self-medicate and have them work with you, because it's all reimbursable by Medicare. It keeps you at a Medicare skilled level longer. But if you start doing self-administration right away, so you're ready to do that when you get home. What are the standing labs that you had outside of the nursing home, and making sure the standing labs continue while they're at the nursing home? And if they can transfer those test results over to the nursing home, it will help so they can do a comparison. Next thing is, what are the signs and symptoms? What makes my spouse different than that other person if they're having a change of condition? What indicates that they're having a sinus attack? You know, if you live in the Midwest, there's certain allergies that happen. Letting the nursing staff know, because it could be an indicator of pain or discomfort. How many falls are at home, and when a person fell at home, what did you do? Did you normally go to the emergency room? Did you doctor it up yourself? How did you handle falls at home? And letting nursing staff know right away, what kind of bed was at home? What were the things that were used at home to keep that patient safe? Then what are the indicators of pain? And when you had pain at home, what were the things that helped relax the person? Are you a CBD oil person? Was it heat? Was it ice? I had one patient that my nurses called me and said, hey, you know, we've got a problem. I was doing rounds, and they go, this person, all they do is sleep. And so I went and sat down with his wife and said, does he sleep a lot? She goes, oh, he sleeps every afternoon. I always give him a little brownie. Okay. We're going to have to take a look. I'm not taking your brownies away, but but it had never been communicated to us. And then you figure out how we're going to work around this and what we're going to do. But the patients of today are looking at their marijuana brownies, even though they're not supposed to bring them into the nursing home. Their CBD oils, which they don't have a plan. They're looking at all of these things. And so being open and honest in communication on that. And the next thing we look at is patients and how many pillows do they really need. Nursing homes issue you one plastic pillow. So if you need to bring a pillow from home, let's go ahead. Let's talk about sleep hygiene. If you had a suspicion on sleep apnea, do you have a noise machine that helps you sleep? And like I said, does that person really know you're not sleeping with them at night, because they make assumptions? Do they like to sleep with the TV on and off, and do you need some headsets for them if they have a roommate? And then what to wear. Believe it or not, when people have to be in a nursing home, it's like going back to high school again. People judge you by your clothes. So for men, I always recommend get those longer gym shorts, nice little tank tops. They wash nice, and if they have to use the bathroom, they have to pee, all you got to do is just lift that leg and throw in the urinal, and, and I always tell people, have a dozen of them at home for yourself, because you're going to need them in the car and everywhere else. But there's nothing worse than going into a nursing home and feeling like the new kid in school. Got to dress cool. So don't go get them house coats, or they want to dress cool up there. So you got to do that. Showers or baths are how often? And when people go and say, when, like nursing homes think they can, I have how much time? Oh, geez, Louise, okay. Shower and bath, and how often? My staff, what they did with my husband was they gave him a whirlpool bath every night. And it's like in nursing homes, we get real traditional about how much time a person can have in getting a shower once or twice a week. No. You're the customer. You walk in there. If you want a shower every day, there's no reason why you can't have one. If they say, well, I don't know, it's like, figure it out. You have to do that. We are consumers of today. Internet, make sure you've got that. Options for dining room. Coffee, is it real or not? Because the doctor talked about caffeine last night. And is there room for a cocktail? If you're used to having a drink, why can't you have it at night? So talking to them about that. And privacy. The biggest issue the patients worry about is, if I want to grab my wife, can I? Yes, you can close the door. And if I close the door, that means knock 3 times before you're coming in. So clarify that. This is today in a nursing home. It's not like yesterday. And then for the spouses, it's okay not to be okay. It's okay to feel bad about this disease, because your life has changed. Panic, fear, guilt, it's all normal. I felt so bad that my husband's cancer that I didn't get it instead of him. So sometimes when wives are having a bad day, when they come to visit their husband in a nursing home, it's totally normal. And just remember, your life changed. Your life changed, and you got to move on to option 2. So keep a journal. Make entries before you sleep. Write down, if you're angry and upset, write it down, and then meet with the nursing staff the next day. Because sometimes you just can sort through this, and it makes it easier. Identify your lifeboat people and how they can help you survive. There's going to be certain people that are going to help you get through this Parkinson's disease walk, and those are those lifeboat people that you can count on. And when they say, can I do anything for you? Yeah, let's go to Starbucks and have a cup of coffee. Don't say, no, I'm okay. If people want to help you, you got to learn to accept help. I'm going super fast right now. And we want life to be fair again. We want our old life back. We're in the struggle of our life, and we just can't fix it. And that's the part that just hurts so bad. Our roles and responsibilities have shifted, and we need a crystal ball, because we go, do I have to win the lottery in order to survive this? Should I be quitting my job, staying with my spouse? What do I do to get through this part of the journey? Is my house even going to work when we get back? Those are the scary things of this. And I'm afraid of I'm worried about dementia. Sometimes my husband would hallucinate, and learning how to handle that, and having the nursing staff work with them now on how you handle hallucinations. My husband told the nursing staff that I was a porn star and that my films were on the bladder scanner. And it was like, oh my gosh, but at least recognize that. And when is the next shoe going to drop with all this? So family and friends are very well-meaning. Everybody reads the internet, and they'll call you up and they'll tell you what the internet said rather than you going according to what the scientific data is right now. You question your decision on did sending somebody to a nursing home for a short period of time, was that really the right thing to do? But you have to do what's right for your family. The case of the Miracle Shrine. People told me, here's my husband the last week of his life, and someone says to me, you didn't go to the Shrine of Mary in Green Bay? And I'm going, no. Well, you really should have, because many miracles have happened there. So again, I rented my van for $450, and I said to my husband the week before he went to hospice, okay, we're going to Shrine of Mary. Obviously, that's one thing we forgot to do besides going to every expert in the world. We drove to the Shrine of Mary in Green Bay. It was outside of Green Bay. We get there, and the shrine is not handicapped accessible. So like, I said, you're staying in the wheelchair, I'm running down there. I left him in the wheelchair van. I run down there. Some dog from the Shrine of Mary got in the car. My husband's petting a dog, and so that was the biggest miracle of the day. But well-meaning people second-guess you. If you have Parkinson's, if you're a caregiver of Parkinson's, you're trying to do the right thing, and people always will go, have you thought of this? And it's always, oh, thank you, that is just such a great idea, but you're the one carrying that burden, and it's always on you. And I asked someone, and I apologize because normally I do this talk in 2 hours, so I'm like kind of cracking. The most important thing I want to tell all of you right now. I understand your journey. I understand what it's like to love someone in your heart more than anything else in the world. Just live it every day. Just enjoy each other every day and do what counts, as crazy as it'll sound. We made the decision the last 5 days of my husband's life that we were going to be going over to the hospice because hospice would be a better choice for us so we could enjoy those last 5 days, and I didn't have to be a nurse anymore, and I could be a wife. But we talked. We talked about everything. We talked about, I gave my husband time to really talk to his kids, to really hug those grandkids. And when he talked to his kids, you know what he did? He said to my daughters, look, he goes, I'm not going to be around for our 50th wedding anniversary, and I'm really upset about it. I don't care what your mother says, get the van again. And they did, and they went to the jewelry store, and he picked out my 50th wedding anniversary ring, even though we had 4 years to go. So this ring was given for my 46th anniversary because he said, I won't be there for the 50th, which was this year. And he goes, but you're not getting gypped out of jewelry. So here's this sick guy, and that's what's going to happen. But most importantly, the message I like to leave with caregivers is the very last day of my husband's life. Second last day was our wedding anniversary, and he said, I'm not dying today. That would be tacky. It's our anniversary. He says, but tomorrow, I think it's going to happen. So on that day, I crawled in bed with him at the hospice. And I just said, this has been a rough journey, but I wouldn't have done it any other way with you. And he had his head on my shoulder, and the last hour of his life, he looked up at me and he said, Betty, you know when you were your best? Now, I have been a fabulous wife, one of the best that's ever been out there. And I go, when have I been my best? He says, when you were a director of nursing. Like, really? Everything, Christmas, holidays, weddings, and director of nursing, I'm working. And I go, really? Director of nursing? And I go, yeah. And he said, but you were never a director of nursing. I said, I wasn't. What was I? He says, you were a director of angels. I see it, and you don't. And that has been left in my heart because if he was seeing something that I didn't see, he saw us all as caregivers, as angels. And maybe each and every one of you in this room have sprouted wings that you're not aware of. And that when we have the privilege of caring for people and partnering with them in this journey of life, it's the most important privileged thing that we do. And so when you go out there, we're truly blessed to be able to do this, but you have no idea what a blessing you are to families, to the people that are suffering day in and day out. So, as my husband said to me, and this was also his holy card at the funeral, it says, life isn't about waiting for the storm to pass. It's about learning to dance in the rain. And that's what we did. And I honor and respect every family member who has to do that dance every day. Because some days you're jiggling around like this, right? And some days it's a beautiful waltz. But at the end of it all, you're blessed with love. And it wouldn't be possible if it wasn't for caregivers like you. So don't discount what you do, because you're all truly a blessing from God. Thank you.